So I think that, like going back to we can't operate in a silo. We have to gather a lot of facts, obtain a good history, figure out like what are they on hospice for exactly? Is this related? Is this not related? Have a long conversation with the family to figure out what they and the patient would want, and then call you all. And if we can't get a hold of you all, call the have some reservations in this, calling the ER physician. Now, I'm sure your husband would be a great person to talk to if we were lucky enough for him to be working when we called.
Yeah, it is always great when our patients come in when he's working. I'm like, all right, like we kind of know, the dance.
But a lot of physicians that we call in the ER, they might not be comfortable, saying, leave the patient at home. But I think it's all in how we word it as well, because if we explain thoroughly that they're on hospice, this is their prognosis, it's related to what they're on hospice for, the family, their goal is to not be transported. I want to give these medications, make them comfortable, leave them at home. They're going to follow up with their hospice care provider.
Yeah.
I think that then, because, if we say the treatment that we would provide under normal circumstances, or that they would provide, would be what's the word I'm looking for? Futile. Like the normal treatment for this condition is futile. Do you want us to provide this futile care? And I think most docs would say, okay, well, should provide it if it's futile.
Right. And like you said, again, patients and families are just sometimes looking for that reassurance and direction that we can keep them comfortable without taking them, back out of the home.
But then again, like you were talking about with your example with the GI bleed, I think another example that I heard was
a stroke is a good example with somebody. Like, say they're COPD and they have like new stroke symptoms. That's clearly something that most people are going to want to go. Right. Even if they're like, we don't want anything, we want to know. And I'm like, it's hard to fault them for that. They want to know. And they may get there and get the scans and say they've got it and we're not going to do anything. But it's still hard to deal with in the home, right. Whereas we do get some people maybe at a nursing home and they get the stroke symptoms and the family's like, we're not going to do anything about it, leave them there. But it's still different when you're taking care of them at the house. Right?
One thing I was thinking of was like an advanced infection, maybe like sepsis, which, it could kind of disguise itself.
Yeah.
But if we took them and they were treated for it, it could possibly buy them more time with their family. Would that be something like a treatment that would be covered still under the Medicare hospice? Or? Yeah,
so definitely that is a big one. Where again, a lot of these like older dementia, right? They get these recurrent UTIs and aspiration pneumonia. And kind of my education of people is like you're hitting that fork in the road of how long they can take PO antibiotics and treat this versus when do they need IV, when do they need fluids with it. And right, if you're doing IV fluids and IV antibiotics, then right, you're going to extend their time because you're treating that infection. Versus the people that say, okay, give the oral antibiotics, and then once they can't take it anymore, I understand that's we're going to draw the line there. So you don't necessarily there's sometimes maybe differing opinions, like whether if they want to go and get fluids and antibiotics, like that is related. That is considered part of their disease process when infections are common. So yeah, hospice will pay for that. Now, will we necessarily jump to offer it? Again, we want to kind of talk to them about, right, when you came on hospice, what is your goal? Like, how many times do you want to continue to do that? Because this is part of this patient's end of life process, especially with Alzheimer's, or, you used to hear pneumonia is the old man's best friend. It's part of what happens a lot for these people. So we can continue to treat, but then, is your goal still consistent? So sometimes we will. again, it's easy to say that, and faced with it, you're like, well, if we treat this, then I can give them, a couple more weeks or a month versus.
That kind of care, would you still consider that comfort care?
I argue that I can make somebody comfortable through an infection without giving them antibiotics, because a lot of people will say, oh, for a UTI those are really uncomfortable, they need the antibiotics, and I'll argue, well, we can do things, but it is, if their terminal diagnosis is a dementia or something, it's, if that's something that still somebody wants, it can be part of their comfort care, right, people have autonomy, they have decisions to make. There's still some things that we would, that I wouldn't recommend, but I'm not going to say, this is outside of a hospice plan of care that you need to revoke at this time to seek it. Some of it's how aggressive is it, right? If you're going to go in the ICU with pressure support, then I'm going to be like, okay, I'm not going to do that. I'm not going to order that for you. We're going to revoke right now versus a little fluids and antibiotics. If hospice is really still the right thing for you, then we should continue to support you through that.
Okay.
And I mean, the symptoms of sepsis are pretty similar to the symptoms of dying, the vital signs, presentations. But
it is. I mean, it's a hard thing, again, to wrap around somebody's brain when they're like, somebody gets an infection and you treat it. But, right, if they can't take antibiotics for it and they need IV route, or these people that start getting the resistant UTIs that only an IV antibiotic can treat, again, that's when we start to have those conversations with them about, are we going to transport to the hospital for that, and again, if they're not ready for their own hospice, but they still weren't ready for this moment, then, of course, you're going to support them through it.
So does Medicare allot a certain amount for hospice?
Yeah, so we have different levels of care. So typically somebody, in the home setting, right, they have what's called routine home care, and you just kind of get a daily rate. And my numbers are going to be horrible, but say it's $200, $300 range per day.
Okay.
When they go to the hospital, we call that GIP, general inpatient. And again, you can still be on hospice at the hospital. We have, the care center, or a Baptist, people get admitted to hospice just in whatever bed they're in. And that's more like an, $800, $900 range of what Medicare hospice benefit is paying. Then we have respite care. So, somebody doesn't need the hospital, but their family may need respite from taking care of them 24/7. I can't tell you what the rate is right now, but you just know it exists. And then there's places like in Northern Kentucky, we don't have a hospice unit, and we don't have any hospitals that we contract with because they're all St. E. So there's something called continuous crisis care, where we'll put a nurse in the home for 8 hours to kind of help when there's some symptoms and the family's needing a lot of help so almost like they would probably, here in Lexington, they'd probably just go to the hospital, but since we don't have that up there, you've got the nurse in the home to provide the care.
So can they run out of that allotted amount? If, let's say they call every day because the family's just struggling and they want to transport it every day unnecessarily.
Yeah. I mean, I'll be honest with you, I'm not sure who kind of eats the cost of this stuff that, again, we get a daily rate. So if somebody when they go to the ER and they go in the ICU and they're still on hospice care, we're getting that billing. I mean, I'm sure the hospital, they eat some of that cost for some of the care provided, that just like any other insurance, what they'll end up reimbursing.
We heard that on another webinar that they partnered with their local hospice agency, and EMS service did, because they were having patients that were, I guess, running out of their allowed Medicare hospice funding or whatever.
Mm-hmm.
So, and that it ultimately benefited them in that aspect, that they still have that those funds available.
Mm-hmm. I mean, there's different people that are at home, say, it's again, the best way I can describe it to people is kind of like any other insurance. We have formulary meds. We have kind of some of these people that are say they're on Entresto for their heart failure. Well, that's a super expensive med. It's $500 a month, and our philosophy is, well, if you're in stage heart failure on hospice at this time, that's not really benefiting you anymore anyway. But of course, again, people hold on to what they know and is familiar and is what. Now, this is the cardiologist told me to take this, So sometimes, those things we will prior authorize, like allow time for education, or, we know, hey, this person's not going to be able to take this much more anyway. The COPDers with their inhalers, well, some of them aren't even taking those inhalers appropriately anymore. They're clearly not able to coordinate the puff, there comes a point where we say, right, if this is the right thing for you, a hospice doesn't just say no only based on cost prohibitive, but we're like, again, is this truly benefiting you for us to utilize, funds for it?
That makes sense.
Mm-hmm.
So when our normal approach to showing up on scene, someone's really sick, is go there, we tether them to the bed with all our monitoring stuff, and we throw lots of oxygen on them. I think, it's going to be a little different for us. Our demeanor has to change if it's a known hospice patient, or we show up on scene and we start doing that, and then the family says, hey, they're on hospice or palliative care, then we kind of, maybe not palliative care, but hospice, then we kind of have to slow down a little bit, take a different approach, and our demeanor would have to change slightly. And are there any specific recommendations, like, maybe get down on their level, allow their family to come and hold their hand, and like Jared said earlier, like silence the alarms on the monitor?
Yeah, I think that's great. Again, the people that are in the ICU that are comfort care, right? The nurses are still leaving the monitors on out at the desk because they want to know what's going on, or they want to know when the patient passes. But, right, for the family's view, like you said, you kind of normalize these things as part of, like, again, they may need some help with the comfort side of it, but these things are part of a dying process that are normal, and it's okay, and we can, help you through it. But again, just showing up, like you said, like everybody's full, somebody in distress or dying, like, right, everybody's, what can we do? Like, let's do. And again, coming in and just finding out what their goal is of, like, why they called you. Do you all just need help? Like, you feel like they're in distress and you just want us to help out of that? Or do you want aggressive things? Or do you not want aggressive things, but you just can't handle it here at the house right now?
If they're actively dying, you'll sometimes say, do you want us to move them to their bed? Or like if they're on a couch or a chair or something.
Yeah. You definitely would ask that.
Where would they want to die?
And that's another thing. If you guys got there and you're like, this person's clearly actively dying, like, I feel like they could die any minute, and you kind of bring that to the people. Like, we are happy to transport them to the hospital, but they could die en route. Like, are you okay with that? Because we've had people the opposite that are at the hospital that look clearly like, I'm worried that they could make it home, but some say, I would rather them die in the hospital because they would want to die at home. And like, me knowing that we tried to get them there, it's okay.
Yeah.
We've had people say that.
Now, do you, if they're in that active dying process, do you do anything with the secretions if they have excessive secretions? Do you suction them?
So suction can be tricky. Some people sound like a freight train, right? Just awful secretions, even come out of their mouth. So we will suction in kind of cases like that, but we also educate. That can be a catch-22, right? Stimulating, putting something back there to suction can also stimulate more secretion. So it's a balance. Again, when it's that bad, obviously it makes families feel better that you're doing something, but just kind of educating them that sometimes we'll do it, but it could actually just stimulate it to come right back. And, for a family that's not medical, you say, like, think about, put your toothbrush back there.
Oh, yeah.
Right? You salivate, like you gag. And so, that's where we'll get Levson in the home and do the scope patches if somebody's kind of rattling and having a lot of
Dry them out a
secretions.
little bit.
Yeah. And again, you say it sounds very distressing. Obviously, it is, but they're not actually choking on them. You know, it's. You think if you had that, like sometimes you want to clear your throat, but you're not actually, choking on those secretions. It just sounds really bad.
Do you give benzodiazepines for anxiety?
Mm-hmm. Mm-hmm. I definitely do that. Like again, if we think, some people when we talk about nonverbal signs, sometimes like people are just restless. It seems like you feel like, well, I'm giving them their opiate. I don't feel like it's pain. I feel like I'm treating that, or I feel like I'm treating dyspnea, and they're still just kind of restless, pulling, that kind of stuff. Or other ones, the big ones we'll see is just somebody that might open their eyes and they just kind of look anxious and fearful when they look at you. And it's like, I'm gonna give
Maybe
them.
I'm sure they can still lacrimate, tear up,
Mm-hmm.
and just.
Mm-hmm. And then again, we'll use Seroquel and Haldol just if it's, especially the dementia folks that have had like hallucinations or seem like they're like, it's a fine, determination on do you use a benzo or a Seroquel Haldol for when somebody's kind of restless. But with dementia, like if the Ativan's not enough, then you go that route because you see picking and or if they had hallucinations or just more combative or aggressive kind of behavior.
I think we have a pretty liberal benzodiazepine protocol.
Mm-hmm.
We also carry Versed and ketamine, so those are.
Mm-hmm.
That's
me. Sorry.
Go ahead. That's fine.
It's okay.
Now, they're going to be dehydrated, right? Because they're not going to be eating or drinking for a long time. Do you ever administer IV fluids for dehydration?
So, again, like I said, or it's kind of like we never say never, but not my usual go-to, not usually encouraged. Again, if you think that they're like really close to end of life, is that going to provide comfort? No. Is that going to possibly prolong things? Yes. I mean, it's amazing how much just like a bag of fluids I feel like somebody with their presentation coming into the ER, like you said, probably septic, and I would think like they probably would have had a couple of days, but they get admitted overnight until we can take over, and they get a bag of fluids, and they're there for like a week and a half, And my best way to explain that to people too, and they're like, they're not eating or drinking. How can it be this long? Like we thought it was 3 days, and I'm like, they're laying in bed. Their metabolic need right now is just that heartbeat and their breathing. It's like so that little bit of fluid kind of went a long way. It's really surprising, but
well, even on the not dying patient, like. If you give them a bag of fluids, it's amazing how that.
Yeah, and they do feel better, but again, we can use other things to make them feel better. Now, again, sometimes I've given fluid on people with like bowel obstructions and that intractable nausea and vomiting, but they're not kind of in that minutes to hours range. They're in that. I think they're still around here for a couple weeks and they're miserable. Like I'm going to give them some fluids for that. But at the end of life, we usually say, honestly, it's probably going to prolong things instead of really be true symptom management. And then again, some folks where, CHFers or some people, is it just going to third space? Is it just going to start causing secretions? Is it actually going to go to the right places? If they're so malnourished, they might third space, or they might, they're already CHFers. Like, they're dehydrated, but still there's that little easy balance of overloading them too, and then they're going to have secretion. So,
and I think only like a third of the fluids that you get actually remain in the vascular space anyway, so they're probably going to make them swell up.
Right.
More so. And I think it goes back to like, where are they at in their dying process? Are we talking weeks or months? Or are we talking minutes or hours?
Yeah, yeah, exactly. So it's just like when you asked about like the antibiotics, if they're kind of not ready, if that person just stopped eating and drinking and that family's just not ready, we know this is a temporary fix to give them fluids, but we're just buying them some more time for them to get there. Or, again, a lot on people with hospice of that. We never say no, automatic, never say never, just because, or do we have somebody that's clearly terminal and they're just trying to get to the grandbaby's birth or somebody's wedding like in a month? Then we might do some more things because, we're trying to support that goal. Again, it's quality of life.
Yeah, I mean, we want what we do to be in line with the patients and the family's values and their goals. Like, what would they want?
Right.
That's ultimately what we're trying to achieve.
Right. And like you said, it's hard with of course, there's legal. You always have to have those things in place, but when clearly everybody's on the same page, like that should be easy. The ones that are like, well, one family member says yes and one says no, well then okay, we gotta go. We gotta cover our butt and go with aggressive treatment if there's controversy, right?
That's why we don't want to do this ourselves. We want to call hospice, or call the ER physician and come up with a plan.
Yeah.
I also think, we're not good at necessarily crisis communicating with the family. Now, we've had some, a few years ago now, probably actually about 3 years, we started not transporting every cardiac arrest patient. We'd resuscitate them on scene, and then if it was, determined that they're dead, we'd declare them dead, communicate with the family. So we had some training on that, and I'm sure it's probably the same where we don't say, I'm sorry they passed, they're not going to make it. We reaffirm that they have died.
Yes.
To help with that grieving process. Is that what you all do?
Yes, absolutely. Like you said, you do have to use specific, say they died, there's no heartbeat, there's no breathing. Like you said, kind of don't beat around the bush, because when we use that vague terminology that everybody assumes, but everybody is not necessarily on the same page with that, right? So, yeah, you always want to use the words died.
And I mean, everybody has different belief systems too.
Mm-hmm.
I think we've got to be conscientious of that. So anything specifically, I've got a list of things that we saw from a lecture of what not to say.
Mm-hmm. Mm-hmm. Well, and again, you have great examples of a lot of people do say that we'll do everything, and
what's that mean?
Right, like it's sort of, well, we're not sure like your understanding about that, or I'm just going to tell you my biggest pet peeve are people, well, I want to be a chemical code, or I want compressions, but I don't want intubated. And I'm like, when I would have these conversations with people, I'm like, I don't even allow them to choose that option. I'm like, that's not a real thing. It doesn't work. There's, like you said, that is a futile thing to say, I want compressions and I don't want intubated. I'm like, well, then you're not circulating any, So I try to tackle that, whereas sometimes, like you said, when people use vague things, then we get all these crazy code statuses that, like, or again, I want a chemical code. Well, if you're not compressing, again, you're not circulating drug. Like, so, like, why do you don't even offer that? It's the same, like your question, like, are you required to provide fetal care? Like, no, because some of these things, it's like, this is not a real option. We shouldn't offer it. We shouldn't say we're going to do it if, honestly, we're just going to waste resources, to tell. It's not that we don't want to do nothing. Like, the other question of, like, there's nothing more we can do. That's never true. Like, we can provide comfort, dignity, education to you. That's my favorite way to tell people our focus is just different. Like, I'm keeping you here in the hospice, in the hospital on hospice, providing comfort care, and we're doing a lot, This is a lot of care.
Yeah, we're doing a lot.
Yeah, we're doing a lot of things, So again, right, it's just a different way to describe it and reassure them that just I think a lot of people are scared to not be full codes because they think you're just not going to do anything. And that's not true.
We're gonna make them comfortable and let them die naturally.
Exactly. And that's always, I think that's great terminology, die naturally. Like, this is something, that's one of my favorite things to say when tackling like the nutrition and hydration issue for families. Right? That's huge. That's everybody. Well, we don't want to starve them. Like, we don't want to stop that thing and stuff. And I'm like, naturally, when our body is dying, it does not want
all this stuff.
Yeah, like, it's not utilizing it. And again, going back to, are we going to cause secretions? If their body's not even digesting it, then they're going to reflux. They're going to vomit that. And then they're going to aspirate that, and you're actually causing like more harm than good by doing those things. And just putting it in that perspective, like, we know we take care of everybody. We celebrate, we mourn, we do everything with food, right? But
you keep them warm. You make sure to keep them warm.
It's just different when, it could cause harm because our bodies are in a different place at that point. So. But I love the examples. Again, just going back to what's important. What do you think they want right now, or what do you think they need?
I think, Jared, you have added some questions.
I think we covered them pretty well. I was just going to say, myself included, I feel like a lot of providers have trouble not being that direct, especially when it comes to something. Either somebody's like actively dying, or they've already died, and you have to communicate with the family. And so it's hard to kind of to separate ourselves from that emergency treatment standpoint to now we're here to just help the family through this. Yeah. So, I mean, you can, like you said, with our examples and everything, is there anything you would want to add that maybe we could to change our verbiage with how we approach the families with this?
Just like specifically when they're dying or when they've already died? Which part?
Either way.
Mm-hmm. I mean, again, I think also, even if they haven't already died, like you said, saying they are dying, like, I think that's a really good. It's hard to say, but to say, like you were talking about what's futile, like, even with the things that we may do, like, they are dying right now, and using those words and emphasizing, like, where do you think they want that to happen, and where do you want that to happen,
and I mean, we use the word resuscitate a lot. I think if we say, do you want us to resuscitate them? I'm like, well, yeah, because they might think we could get them better. It's like we're not going to get them back to where they were. At best, they're going to most likely be worse off.
And that's probably a really good point. Like, right, to resuscitate them. So again, what's that mean? Like, if I resuscitate them, so right now, this is again my favorite terminology. I'm going to prolong their dying process. They're still going to die, but am I as opposed to with palliative, like we said, the things we're doing is curative to prolong life, or am I doing things that are going to prolong their death right now? It's not going to fix them. It may give them more time, but again, are they going to be awake? Are they going to be with you? Are they going to be able to return back home?
Yeah. Maybe even going as far as explaining, like, if we do all these things, and we take them to the hospital, they're probably going to be, if we do get a pulse back, they're probably going to be on a vent. They're probably, going to be on multiple medications. They're probably not even really going to be able to understand that you're even in the room. So.
Right. Because like you said, a lot of these, even the older folks that they've never talked about, well, of course I want you to do everything. Like, yeah, do CPR, put them on the breathing machine. And you're kind of like, you would hope that they've had those conversations by now, especially if they're on hospice. But one of the other points of, like, can you be on hospice and be a full code? Yes. So, again, that was something that was hard for me when I started doing this. I'm like, this sounds crazy, but, our philosophy is that, again, people have the choice Like, we don't want to force them. Our goal is, do we want to deprive them of hospice when they think they are terminal? They do really need us. Are we going to say no because they say full code when we could come in and hopefully have the time to educate and get them there? Yeah. And that's why you have a lot of people that are that still may be full code that we took, and you're thinking, well, they weren't there, but we're like, we hope this is truly what's right and what they need, and can we, get them to that point and educate. And that might be why, like you said, that they don't have the papers. It might even be that they do really want to be not a full code, but there was that one out of the 4 kids that had a hard time with it. So the parent didn't want to sign it yet because they didn't want to feel like they weren't listening to their loved one. You know what I mean? Or the family, or the kids are still gung ho and the parent's tired and they're like, I'm ready, but I'm going to give my kids a little more time, So sometimes you do get into that. Or we've had, I think, just saying, DNR is hard for people even when they don't want things. I've had some of the pediatric cases where they're like, we're not going to call 911 when he dies. We're going to call you, but they can't sign that paper that just says DNR,